So our next speaker is Dr. Rahul Prasad. He'll be talking on different kinds of electrodes of the machine, along with the glimpses of machine. The machine is one with different parts, and all these tests are done through that machine. So, Dr. Rahul Prasad.
Very good morning, and thank you, sir, for including me in such an important topic for our ophthalmology. Of course, it's a developing field in the retina. It's a very important investigation these days. So, continuing from where Dr. Vibhuti left, I'll be talking upon the machine and the electrode parameters. Now, to record an ERG, it's important that we understand two important factors. Number one, the basic technology, and second, the clinical protocol. The basic technology includes understanding the electrodes that we use, the stimulation of eye by the light, and the electronic recording devices. The clinical protocol includes preparation of the patient, understanding the ISAF standard ERG, and finally, the analysis and the reporting of the ERG. First, the electrodes that we use. Now, there are basically three different kinds of electrodes that we use. These are the active, reference, and the ground electrode. The active electrodes are those electrodes that captures the stimulus from the retina and the surrounding. The reference electrodes are those electrodes that captures the stimulus from the surrounding, and then we have got the ground electrodes. The electrode stability is maintained by a good connection as it decreases the impedance. More impedance means more noise, and that leads to a wrong reading. Remember, electrodes have to be kept very clean to avoid infection and also for its reusability, because some electrodes are very, very costly. And also, cleanliness also decreases the impedance. Now, for a good recording by an active electrode, we have to ensure that we use a non-irritating, non-allergic, ionic conductive, non-viscous solution. Ensure a very good contact to ensure proper electrode impedance. Then, as prescribed by the ISAF, we should define both normal values and variability for our own laboratory. Now, the different types of active electrode include the conductive fires, foils, conjunctival loop electrodes, and the contact lens electrodes. Now, these contact electrodes are centrally transparent with an optical opening, works like a lid speculum, gives the best recording, and it is stable with the highest amplitude also. Then we have got the skin electrodes that are mainly used in children. The corneal ERG electrode consists of two types, the monopolar, those are jet contact electrodes, and the bipolar, that is the Burian electrode. But the most commonly electrode that we use are the DTL electrodes. Also, we have gold foil electrodes. The reference electrodes are incorporated into the contact lens speculum assembly when you are using a bipolar electrode, such as a Burian electrode for stable configuration. Now, these electrodes are placed near the orbital rim or the earlobe or near the forehead. The third type of electrodes are the ground electrodes, where we have got a separate skin electrode which is attached to an indifferent point and connected to the ground. Typical location are on the forehead or ear. Now, what is an actual electrical impulse? Remember, the active electrode, it captures the action potential and the impedance, whereas the reference electrode captures the only impedance. So, if we subtract that, we get an actual electrical impulse. This is actually done by the amplifier or a signal averager. Now, coming to individual electrodes, the first is the ERG, those are jet electrodes. These are disposable monopolar contact lens electrode, gold foil electrode or polymethylcrate with lead wires. It's very easy to insert, but movement of lens during recording and absence of lid speculum contribute to the variability of the reading. It reduces possibility of eye infection. The only drawback is the gold plated itches off with time. Then we have got the Burian Allen electrodes. These are bipolar, again reusable contact lens electrode, the built-in speculum with lead wires, customizable to various sizes. These are ideal for testing infants. Reference electrodes are built into the electrode itself. The PMMA shows variable degree of blurring, so it's not suitable when we need ERG where full clarity is very much vital. This is usually used for a full-filled ERG, but remember, these are very costly electrodes. Then, the most commonly used electrodes are the DTL plus type of electrodes, which we are seeing in the picture. These are conductive fibers, 50 microns, negligible mass, low cost and disposable, convenient to use, and they give very clear images, no interference with pupillar optics. They have got a very reliable ERG recording, and they are well tolerated by the children. Then we have got the gold foil electrodes. When you cannot use a contact lens electrode or we don't want to anesthetize the cornea, we use these gold foil electrodes. The ERG amplitude will be substantially affected by these electrodes. It requires an adapter. Now the other types are the reference and the black ground electrodes. Now there is a color coding for different electrodes. However, different companies have different, but on most commonly that we use are active refers to the red color, reference electrodes have blue color, and the ground electrodes wiring are black color lenses. Now for preparation, it is very important that we use a good gel that actually that has got a very good cleaning effect and can decreases the impedance. Now, which is usually used by a skin prep gel. Now, then for the cup of the electrodes have to be filled with gel that allow a better conductivity. 10/20 conductive gel is one such set. No financial inclusions. Now, coming to the amplifier, we have got two types of amplifier. One which has got a one channel, which has got an active reference and a ground electrode attachment. And this is the second two-channel electrode, which has got an active and reference electrode attachment. Test for one eye is usually done by using one channel, while tests for two eyes are used for two channels. Then coming to the machine consists of usually three parts. First is the computer monitor, which tells us at what stage the investigations are we in. And then we have got the stimulation part, which we have got the central monitor and the Ganzel field ball. The central monitor gives us about the pattern stimulation, and the Ganzel field ball sets up about the flash stimulation. Now this is a side view of the patient showing how the electrodes are placed. Now for a multifocal ERG, usually we close one eye and then we proceed with the test. The movable chin rest is to be placed in front of the monitor. The chin rests with the monitor and the fixation point as shown in the picture. Then monitor displays random pattern of the multifocal ERG, and which is further recorded on the by the electrodes. Now, once that test is completed, we can move the patient to the Ganzel field ball. Then baby flashes are used for babies and unconscious patient. A closer view of the Ganzel field ball. When the test is not used, the movable chest rest is attached to other place which is not required. Now this is a schematic diagram showing how electrodes are placed. Now for a recording to the ERG, test procedure must be fully explained to the patient. As the test requires, pupil may be dilated freely. Remember, always note the size of the pupil. Patient are dark adapted in a dark room with an eye patch, and electrodes are attached with a dim red light in the room. Then start the test. Attach electrode and follow the guidance coming on the computer screen. Safety information regarding machines. Remember, if you are using printer or external USB hard drive, it should be connected to a Wi-Fi. Automatic windows should be deactivated. Dark room should be properly dark. Disconnect the power supply before any cleaning. Should not be connected to an extension cord. External drive to have a regular backup, and a password should used to protect the patient data.
Please try and
For the
conclude,
patient,
Rahul.
electrodes should be attached to the damaged skin. Patient should be explained about the procedure, and waste disposal should be done thoroughly in the household waste. Thank you, sir.
Thank you, Dr. Rahul. And I request Dr. Bharti to talk about EOG. EOG is one electrophysiology test which is not done very, very frequently. And this is useful only for some diseases. So she'll be talking on EOG.
I want to full screen. Full screen kar dijiye.
Yeah.
So good morning, everyone. So my topic today is tips on electrooculogram. So a little brush up before the tips. Who is credited with the first description of EOG? The EOG was described by Elvin Mark in 1951. And the clinical applications were described by Geoffrey Arden in 62, What is the principle behind EOG? EOG is the test to measure standing potential of the eye approximately 6 millivolt. Indirectly, the transepithelial potential that exists between the cornea and the back of the eye. Normal light peak requires normal functioning photoreceptors in contact with the normal functioning RPE. This tests RPE layers and outer retina. What's the physiology behind EOG? First, pre-test requirement is that we keep the patients in the normal room for 20 minutes. After that, we expose the patients to 15 minutes period of dark adaptation. There is a fall in the recorded standing potential, and it typically reaches a minimum at 10 to 12 minutes. This is referred as a dark trough. Following light onset, there is an increase again in the transepithelial potential of the RPE, producing the light rise of EOG. The light rise is ultimately the result of increase in intracellular free calcium, which is released from the endoplasmic reticulum, regulated by an interaction between endoplasmic reticulum bestrophin and L-type calcium channels associated with the basolateral membrane. This intracellular calcium gates the opening of the basolateral calcium-dependent chloride channel. Increased chloride causes depolarization of the basolateral membrane, and which increases the transepithelial potential, recorded as the increase in the standing potential of the eye. What are the prerequisites and instructions? Prerequisites: dilated pupil, pre-test 20 minutes normal room light adaptation, full extraocular muscle motility, good visual acuity, refraction correction not needed, impedance should be less than 5 to 10 ohm. Instruction: head position should be stable, eye movement only in horizontal direction. Never anticipate and move prior. Increase illumination in case of non-dilating pupil, and avoid any bright light procedure like FFA before EOG. How EOG is performed? There is a stimulator called Ganj field stimulator. The two LED light inside 15 degrees left and right of the central light, and it is bright during light adaptation phase and minimum brightness in the dark phase. The pupil should be dilated before testing, and after suitable skin preparation by new prep, recording electrodes should be placed close to the canthi of the each eye. How EOG is performed? For the dark phase, total darkness should be maintained for 15 minutes except for the dim fixation light. For the light phase, a Ganj field back illuminator light of 100 photopic candelena per square meter should be turned on. Continue the recording for 10 seconds out of every minute in each phase. Active electrode is at the inner canthi and a reference electrode at the outer canthi. Ground electrode on the forehead, impedance should be less than 5 to 10 ohm. Now here you can see the picture, and you can see that the gold cup electrodes is there. It's very expensive. Black is ground electrode, gold cup, blue is reference, and red is active electrode, which is placed near the medial canthi, and it's very important to, the position is very important at medial canthi. They should not touch, there should be separation, otherwise contamination will happen. Patient has to move his eyes to LED with single sweep with head fixed. Circuits recorded 10 to 15 seconds and 50 seconds rest. 15 minutes in dark and 15 minutes in light. RN ratio. What is RN ratio? RN ratio is LP-DT ratio. Light peak by dark trough. So it is normal is more than 1.8 and abnormally low is less than 1.65. So what are the parameters that should be included in the EOG report? LP by DT ratio, dark trough amplitude in microvolt, implicit time, time from the start of the light phase to the light peak, type of adapting light source, pupil size, and note also any difficulty encountered during testing which may affect the confidence in results, such as inconsistent eye movement. What is reliable EOG? Presence of a square and regularly placed waveforms. If waves are not that proper, that means either patient is not fixating properly or electrodes is moving. Light and dark values taken in the respective adaptation period. Typically, जो trough है वो 12 minutes after the start initiation of the test happens, and a peak, light peak happens at the 25 to 26 minutes after the initiation of the test. What is the relationship between the photoreceptors and EOG? RPE relationship we know. Normal light rise in EOG requires a normal RPE and good photoreceptor. As the light rise depends on the photoreceptor functions also, patients with abnormal rod functions will have a corresponding reduction in light rise, thus mirroring the extent of photoreceptor damage. So, if ERG is absolutely negative, the EOG will be absolutely negative. Some photoreceptor action is must to have an EOG reading. So, we recommend always to do ERG and EOG together and never in a singular form. a bit. In case of good rod function in ERG, a reduction in light rise in EOG is suggestive of abnormality localized to RP, that is the best disease. Now, a few clinical tips. The most common diagnostic use of EOG is to confirm vitelliform macular dystrophy. Patients with best disease and some patients with adult vitelliform dystrophy have normal ERG but abnormal EOG. Now, you see, this is the bestrophin gene mutated dystrophies. Best, autosomal recessive bestrophin, adult onset vitelliform macular dystrophy, and autosomal dominant vitreoretinochoroidopathy. So EOG is grossly reduced in all except adult AVMD. So EOG is abnormal irrespective of any stage of best vitelliform dystrophy. You can see in one is a not clinical best, and other eye it is a clinical best dystrophy. So, but EOG is more reduced in the eye which has no clinical best disease. If EOG in a child with suspected best disease is difficult to perform, तो आप क्या करेंगे? Test the parents, and one carrier parent will surely exhibit abnormal EOG. Debatable role in differential diagnosis of congenital stationary night blindness, where it is normal from other progressive disorders causing night blindness. EOG is also abnormal in photoreceptor layer disorders, Stargardt, retinitis pigmentosa, cone dystrophy, rod and cone dystrophy. Now, these were all slow oscillation EOG. What is fast oscillation EOG? In 2017, ISF standards have included FO officially. The advantage kya hai ki test time is shorter, making it easier for the patient to be tested. And slow oscillation is recorded during 15 minutes of dark and 15 minutes of light. And on the other hand, the FO of the EOG has the advantage of greater compliance because the total inspection time is 15 minutes. Fast oscillation EOG is different from the typical EOG because that was the square form. This is sinusoidal, different, and mechanism of FO is different from the typical square form of EOG. This happens actually at the apex of RP, near the retina, and not at the base. So fall in subretinal potassium reduces the movement of chloride, and this results in hyperpolarization. And होता क्या है इसमें कि light phase में ट्रफ होता है और डार्क फेज में पीक होता है. यूजुअली स्लो ऑसिलेशन ईओजी में क्या होता है नॉर्मली कि लाइट फेज में पीक होता है और डार्क फेज में ट्रफ होता है. इसमें उल्टा हो जाता है. इसका इंपॉर्टेंस क्या है? Role in distinguishing whether CSC is acute or chronic type, because many a times the patient don't know the exact duration of the disease. In chronic CSC, decreasing RP function is confirmed by decreasing amplitude of the light trough of FOEOG. And FO parameters can be used as indicators for detecting the severity of macular dysfunction, functional disturbance, and predicting the visual outcome for this entity. Thank you. So nowadays, I think it is useful to you. And nowadays, electrophysiology is gaining momentum. And I think in soon near future, it will be very common in the armamentarium of the
Right.
general
Thank you.
ophthalmology.
Thank you, madam. Thank you. And we are happy that Dr. Subhadra Jalali is around us. And no electrophysiology society or conference or forum is complete without her. Thank you, madam, for coming. Thank you very much.
We welcome madam.
So I'll be talking about multifocal ERG and full-field ERG. Friends, now you have learned about different kinds of electrodes and the machines and everything. So one of the most important tests that is done in ERG is full-field ERG. So you have to take the precaution that you do not do any tests of such kind that you put light into the eyes of the patients, like inert ophthalmoscopy or lasers or fundus fluorescent angiography or any for that matter, any examination. You must dilate the pupil fully, and it is better that if you can measure the pupil, because many a times we have to calculate how much light entered into the eye. And the dark adaptation has to be 30 minutes, and if you have done any procedure before that involving light, then you have to further increase the dark adaptation time, probably up to 1 minute or even 1.5 minutes, half an hour. So for full-field ERG, the DLT electrodes are the most commonly used, and a lot of people are using even Jerry electrodes. They are the active ones, and the reference electrodes are put in the outer canthus, and the ground electrodes are put in on the forehead. So there are certain tests which are done in the dark adapted area time, and there are certain which are used in photopic conditions. So let's see one by one. If the patient is in the dark and you start stimulating, the stimulation has to be very, very substandard, and please see that there are certain amount of stimulation time and there are certain strength of the stimulation. See, you have to mark that. We have given you a handouts in which it is mentioned there. So the first test, it is done very, very substandard light, and the interval between the two flash is approximately 2 seconds, and the source of the wave is from the rods basically, and it generates from the inner nuclear layer. If you slightly increase the flashlight up to 3 cannula, and the interval is 10 seconds, then you can see the A light is a little better, but this is mainly from the rods and little bit from the cones also, because there is light is on the higher side. And if it is the 10 ERG with a stronger flashlight, you get this is also a scotopic, and the light intensity is on the higher side, that is 10 candela, and the interval between the two flashes are 10 seconds. So it visualizes the A wave better. If the light intensity is only 3 candela lights, but the intervals are every 15 seconds, then the waves that are generated are from the amicrine cells, which is at the ascending wave of the B wave. B wave is from bipolar cells. Now the patient is adapted to the light, and then you give the stimulation. Then let's say the patient is light adapted for more than 10 minutes, then a single flashlight is given from 17 to 34 candela. There is a standard flash, and the interval between these stimuli should be more than 0.5 seconds. The source of wave is A wave and plus part of the bipolar cells, and B wave is basically B for bipolar. Then there is a flickering of the lights. This flickering of the light should be more than 30 flashes per second or 30 hertz. It suppresses the rod system because there is no gap in between, so it suppresses the rod system. What you get is only cone bipolar cells stimulations and their waves. It is a more sensitive measures of the cornea. So by this time we know that if you have to check the rods, you go for the dark adaptation test. If you have to check the cones, you have to go for the light adapted tests. So these are the different kinds of waves you get. So we have talked about the photoreceptors, and mind you, this is a full field ERG. So if there is any damage, a little bit of damage, you have to have at least 20% of the damage of the retina to give you any result or negative result. Suppose if the patient has got some problem in the macula, it may come normal. So if you go to the periphery of the retina, you can see there's a lot of rods and cones and a lot of retinal pigment epithelium, then less of rods and cones, and less of bipolar cells, and less of ganglion cells, and then less of axons. So what you do if you go towards the periphery, the scotopic and photopic phenomena, you get the recordings from the photoreceptors, and in the visual evoked potential that tells you about the ganglion cells layers. In the macula, what happens is there are a lot of retinal pigment epithelium, and then a lot of cones, and a lot of cones get attached to a lot of bipolar cells. A lot of bipolar cells get attached to a lot of ganglion cells. A lot of ganglion cells get attached to the axons. So if you stimulate the macula, you are stimulating most of the cones. So these are the normal responses. And in a normal condition, what we do is we compare both the eyes, the normal eye and the abnormal eye, that is suspected abnormal eyes. So this is normal in both the eyes. Suppose if there is a case of ischemic ACR view, you want to know whether the patient will gain vision or not. So for the prognosis, you can do this test, and you can see that the B wave is the amplitude and the implicit time both are reduced. There are hardly any waves there. In a cone dystrophy also, the cone is gone, all the cone function, all the cone waves are not there. There are many such. We can talk to Dr. Subhada Jalali and ask her for opinions. There are something like negative ERG also, in which the B wave is little lower than the A wave. They happen in certain conditions. It's there in your handouts. You can go through it. Now, the multifocal ERG is very important. It is a new technology. Initially, it was supposed to be investigative in nature. Now, it is developed by Professor Sutter and Trans in 1992. And your first direct, objective, and topographic mapping was center 36 to 40 degree of retinal function in the center. Multifocal ERG responses are cone-driven. And it tells you about the health of the fovea, parafovea, near peripheral protopic retina can be evaluated. It provides high resolution spatial and temporal information from the retina. There are frame changes, and it changes very fast. And these changes are from the CRT monitor. That is, you have seen the checkerboard in the center. It comes from there. So there are a lot of focus in the macular area which gets stimulated. They are approximate, somewhere it is 65 to 103 hexagonal stimulus array. They stimulate that area, they pick up the wave. And for this multifocal ERG, you have to have, the pupil has to be dilated. The patient positioning should be approximately 35 centimeters from the screen. The fixation point is very, very essential. And you will see in your chart, which I have handouts, that in certain cases you have to dilate the pupil. In certain cases you have to correct the refractive error also. So refractive error has to be fully corrected. The patient should be pre-light adapted. And the stimulus recording, if you suspect some disease, so disease eye has to be examined first. And the impedance level should be less than 10. So impedance level, the machine tells you whether the impedance level is okay or not. If the impedance level is not good, the machine will not proceed further. So you have to correct the impedance. What is impedance? It is noise. There is some problem. So you have to sometimes you have to change the lead. So waveform, they are grouped in a different retinal eccentricities. Horizontally it is 35 degree and vertically is 31. And the viewing distance is approximately 35. The responses are obtained from the 6 zones. So why 6 zones? Because there are a lot of toxicities of the diseases, of the drugs, which are, they show the abnormality in the 2nd zone, or sometime in its 3rd zone. And since it is a topographic mapping, so it makes your life very easy to understand whether this is normal or not. So it is always compared. On the right hand side is normal, the left is diseased one, and Stargardt's disease. So it also gives a wave, the positive wave and the negative wave. The positive wave is the P wave, and negative is N1. And you can measure the implicit time in milliseconds and response in nanovolt. But we do not calculate that. It is the mathematical summation, and the machine gives you the overall picture. So friends, if you do have to check macula, multifocal ERG tells you the cone system function at the macula, because there are a lot of cones there. And the other function at the macula could be PERG, that is the pattern ERG. That tells you about the some amount of receptor cells and about the ganglion cells there. With Dr. Vibhuti will be talking about it. So what is the application of the MFVRG? That is macular dystrophies, central serous retinopathy, drug toxicity, inflammatory conditions. And this again chart is given to you in your handouts. In different conditions, what should be the refractive error and visual acuity, etc. And what are the waves to be observed? People have talked about so much. What are the waves? In full field ERG, you have to observe wave A, B, and C. In flash VAP, you have to see N2, which is very important, which is approximately 100 millivolt. The implicit time should be 100. And in pattern reversal VAP, P2 is important. In EOG, Arden ratio is very important. And in PRG, N50 and N95 are important. So if you suspect certain diseases, what all tests should be done is there in the handouts. That is very, very important. So this is one of the normal ones. So it looks normal. On left hand side is the eye which was tested, and by just a glance you see that it looks normal. So